I would now like to introduce you to your moderator for today's event, Jill Filene, MIHOPE team member. You now have the floor. Go ahead, please.
Thanks, Michelle. Hello and good afternoon. The purpose of today's webinar is to brief MIECHV model staff on the MIHOPE study. As Michelle indicated, I will be serving as the moderator for today's session. We will have 3 speakers today. First, Lauren Suplee, who is the Federal Project Officer for MIHOPE. Lauren is a Senior Social Research Analyst within the Division of Family Strengthening in the Office of Planning, Research, and Evaluation for the Administration for Children and Families. Second, Ginger Knox is the Co-Project Director for MIHOPE. Ginger is the Director of Families and Children's Policy Area at MDRC. Third, Sharon Rouser is one of the managers for the MIHOPE study, focusing on working with states and sites. Sharon is a Vice President and Deputy Director of the Policy, Research, and Evaluation Department at MDRC. As mentioned, you can submit questions in the bottom right-hand corner of the screen. Although you can post questions throughout the webinar, we will respond to questions at the end of the webinar. And now I'd like to pass this over to Lauren Suplee.
Thanks, Jill. Welcome everyone to the webinar designed to provide you information on the MIHOPE project, design, and the kinds of supports the MIHOPE team will be providing to states and communities throughout this project. You know, in the government we love acronyms, and it's considered great when an acronym is not only easy to say, but conveys meaning. And MIHOPE is a great acronym for the National Evaluation of MIECHV. It speaks to the hope of the states and communities serving needy families. It also speaks to the hope of Congress in creating MIECHV, that it is effective in addressing the needs of these families in a wide range of domains. The states and sites that participate in MIHOPE have a unique opportunity to be part of this nationally recognized project. They're contributing to the knowledge base that will both go directly to Congress to inform their work on home visiting, but also the information collected by states and sites will provide a rich set of data that's intended to help states and communities strengthen and improve home visiting services, both in MIECHV and home visiting broadly. The MIECHV legislation includes language throughout about research and evaluation, including it calling for the use of rigorous designs and specifically mentioning random assignment. It's clear Congress believes research and evaluation is important. For years now, federal research has been calling for the use of rigorous research in federal policymaking, and MIHOPE is an existing project to fill this role. If you have questions about MIHOPE after this webinar, I encourage you to reach out to Jill Filene or Carrie Ryan when she's back from maternity leave at any time. Their contact information will be given at the end of the slides, and they are here as your liaison to the project to answer questions at any time that they arise. So with that intro, I will pass it over to Ginger Knox to start the discussion of the MIHOPE study.
Thanks, Lauren. So we're going to advance to the next slide. This is a little overview of what we'll be talking about for the next hour or so. I'm going to share the presentation with Sharon Rouser. So first we're going to talk a little bit about just a general description of the project and how the project is being managed and who's conducting it. Then we'll talk a little bit about the key research questions that it will answer and the basic study design. I'll turn it over to Sharon, and she'll talk about the roles and responsibilities of sites that are participating in MIHOPE, as well as the kinds of supports that the study team will be giving to the sites throughout the study, and we'll be sure to leave time for Q&A. So now we're on the next slide. So what is MIHOPE? In a nutshell, it's a large-scale evaluation of the effectiveness of home visiting models that are supported with the MIECHV funding. And it's designed to answer key questions about the program's effectiveness. To do that, we'll need a sample of about 5,100 families across 85 local program sites that are receiving MIECHV funding. And those local programs will be in about 12 states around the country. The evaluation is focused on models that are serving at-risk expectant families or families whose infants are under 6 months old when they enter the program. So even though there are MIECHV programs that are serving children beyond infancy, the evaluation will be enrolling families while their children are in this younger age group when they first enter the program. Now we're in the next slide. Who's conducting MIHOPE? So just like the MIECHV program, the study itself is funded by the U.S. Department of Health and Human Services, Administration for Children and Families, Office of Planning, Research, and Evaluation, and Health Resources and Services Administration, who are collaborating on the evaluation. The evaluation is authorized and, in fact, required in the Patient Protection and Affordable Care Act, or ACA, of 2010. And the project team includes staff from MDRC, from James Bell Associates, from Johns Hopkins University, and Mathematica Policy Research. Next slide. So we're just going to talk a little bit about the broad goals of the national evaluation and then get gradually into more specifics. So some of the study's goals were actually required in the ACA legislation. And those include using a rigorous research design, as Lauren mentioned, both to look at the effects of MIECHV overall and for different types of programs and different populations. It will use a random assignment research design, which we'll be talking about in a few minutes. We're going to be going well beyond delivering sort of one set of impact estimates that would just answer the question of whether the program is working or not. We'll be looking at how the program's effects depend on the program approaches that are used and how the effects vary for different groups of families. Second, the legislation says that the evaluation should measure the effectiveness across all 7 domains of participant outcomes and benchmark areas that are described in the law. And I'm sure many of you are familiar with those domains since you're working with MIECHV sites, but just as a reminder, this means that the study will be looking at the effects on prenatal, maternal, and newborn health, on child health and development, including prevention of child injuries, neglect or maltreatment, as well as indicators of cognitive, language, social, emotional, and physical development, improvements in parenting skills, reduction in crime or domestic violence, family economic self-sufficiency, and also improvement in coordination and referrals of the programs with other community resources and supports. So the evaluation will be looking at all of those different domains. A third requirement in the legislation is that the study should should reflect the national diversity of communities and populations that are part of the MIECHV program. So that includes a mix of urban, suburban, and rural sites. It includes making sure that we have diversity of states and sites in their geography around the country, and also that we will be collecting data from both English and Spanish-speaking families at a minimum. Those are some of the requirements that are in the legislation. The evaluation also has an additional broad goal, which is to gain information to strengthen future programs. Both HRSA and ACF are very interested in really using the evaluation as a tool for improving policy and practice in the future, to keep building more positive outcomes and to reduce health disparities in the future. We're now on slide 6. So you may be wondering, the question we get sometimes is, if MIECHV requires the states to use their funding only for evidence-based home visiting models, why do we need an evaluation of the effects of these programs? And it's true that all of these models do have some prior research that says they're effective at improving, at least some outcomes for families. But there are also a number of unanswered questions that we think MIHOPE will help to answer. The first big question is that the new study will really be answering not just how the effects of home visiting programs in general, but given how they're operating under MIECHV. So MIECHV is targeted to specific high-risk communities that have been identified by the states. It's supported with very specific types of state and local infrastructure for implementing the programs. And the MIECHV programs are also operating at a fairly large scale around the country. So this is pretty different than many of the past studies, which included maybe only one site or one state at a time. We mentioned that the evaluation will cover all of the outcome domains for MIECHV, whereas past studies often only looked at a subset of those outcomes. And one of the most important things the evaluation will do is to use consistent measures of these outcomes for parents and children, regardless of what site or what program model a program is using. And this is important because prior studies really each chose their own specific outcome measures, which made it difficult to compare the results across studies and to draw general lessons for the field. And there's one important implication of this, which is the fact that the national evaluation needs to collect the same data across all the local programs and families means that we will need to collect new data from families rather than relying on the benchmark data that states are collecting in their MIECHV sites. And we're asked sometimes, why can't we use the benchmark data for the evaluation? The issue there is that for reporting the benchmarks, the states were given some flexibility to set individual measures that represented their own goals in their own state context. So if we were going to use those data for the national evaluation, we would not be able to look at the outcomes consistently across all of these different 85 programs that are going to be in the study. The second unanswered question is how the effects of home visiting vary for different groups of families and different groups of programs. So MIECHV can answer questions about the effects for subgroups of families that haven't typically been the focus of a lot of prior studies. The legislation itself names some different subgroups, such as pregnant women under the age of 21, or families who have had some prior involvement in the child welfare system that haven't been consistently looked at in prior studies. So this will be an important source of lessons for how to target and how to design future programs to bring the biggest benefits for families. And a third unanswered question that we anticipate being able to answer in MIHOPE is what's the relationship between specific features of local programs and their effects for families. So this is an analysis we call getting inside the black box, which means really trying to understand how the way a program operates influences its likelihood of really being effective. And we can answer this kind of question because MIHOPE will have so many sites around the country that they will vary a lot in the way that they are designed and implemented. And in turn, we can look at how those operational differences among all those 85 programs seem to be linked with better or worse outcomes for families. So this is a really important opportunity, given the scale of the study, to really learn a lot that will benefit the field. Now we're on slide 7. What home visiting models are in MIHOPE? Of course, the home visiting programs are all going to use evidence-based models that are supported with the MIECHV funding. And as we mentioned earlier, we're focusing on models that enroll expectant families, or those with infants 0 to 6 months old. Third, we wanted to focus the national evaluation on programs that are being used by a large proportion of the local MIECHV programs. So the study will include those models that were selected for implementation by at least 10 states. You're probably aware that this includes 4 of the 12 evidence-based models: Early Head Start Home Visiting, Healthy Families America, Nurse-Family Partnership, and Parents as Teachers. Okay, so we're now on slide 8, choosing states and sites. Is everybody with me? Yes. Just want to make sure I'm on because I'm not hearing anything. Right now, the study team and HHS are in the process of choosing the 85 sites and the 12 states that will be in the study. We just want to mention the main criteria that we're using to make those decisions. So first, we know that we need to divide these 85 sites roughly across these 4 program models. So we needed a strategy for selecting states that would end up giving us around 20 to 25 sites for each of the 4 models that will be in the study. To get there, that means we need to prioritize states that meet the criteria that we've shown here on the slide. So we need states that are implementing at least 2 of the program models, because that will help us be able to separate out the effects of being implemented in a particular state from the effects of operating one particular program model. So states that are only operating one program model with their MIECHV funds are therefore going to be a lower priority for the study. Along with that, to get to 85 total sites, we're going to need most of the MIHOPE states to be states that are funding several local programs, not just 1 or 2 local sites. And finally, we want to make sure that we include states that provide some geographic diversity around the country. And right now we've identified a group of states that meet these basic criteria, and they're in various stages. For example, Pennsylvania has already entered the study, and there are other states that have either been approved by HHS to move forward or are somewhere in the decision-making pipeline. Then within these states, we need to choose which individual program locations will be in the evaluation. And this slide shows some of the main criteria we'll be using to make those decisions. Besides implementing one of the 4 models that we've talked about, we want to make sure to include sites that have some experience with the model they're implementing. So our cutoff is that they should have implemented the model for at least the past 2 years. And that's to make sure that we're not measuring the program's impact for a brand new set of startup sites when we know that it takes some time for programs to achieve a steady state and to operate smoothly. So we're generally going to be including sites that have used their MIECHV funds to expand their programs rather than including sites that are starting up a brand new program. Second, we want to be in sites that have more eligible families in their communities than they have slots that their program can provide. So this has to do with the random assignment research design, which needs some extra people in the community to be in the comparison group. And Sharon's going to talk a little bit more about how that works in a few minutes. Third, we're looking for sites that are delivering services with more than one home visitor. And generally that will be the case given that we know that we need local sites that will be able to enroll at least 30 new families into their program slots over about a year and a half. So that's going to be a lot easier to accomplish in programs that have at least 2 or 3 home visitors in their program. And finally, we would like to see what we call a strong service differential, which means when you look at the community where the MIECHV-funded program is operating, you don't want to see a lot of other programs in that community that are delivering very, very similar services with a similar degree of intensity as the MIECHV program is. So if a community is saturated with other evidence-based home visiting programs in particular, that would make it more likely that the comparison group will get very similar services to the families in MIECHV, and it will be harder to measure the ways in which these families are benefiting from the MIECHV program. So this will all make a little more sense when we've talked about random assignment, but that's one of our criteria for sites. And then there's one other criteria that's not on the slide, and that is that we're excluding local programs that are known to have substantial enough performance problems that they wouldn't have the capacity to participate in the study. For example, if we know that a site has a very high likelihood of losing its program funding for some reason in the near future, we would be unlikely to want to have that site in the study. So this is one reason we've been sharing the names of the states we're considering for MIHOPE with the 4 national program offices so that they can tell us if they have any big concerns given what they know about the individual sites. So we've heard some questions in the past about specifics of the research, so now we're going to go into a little bit about the major research questions that MIHOPE will be answering, and then some information about the random assignment process. So we're now on let's move to slide 10. The 3 main components of the evaluation design. You're probably aware that states each conducted a needs assessment at the beginning of their MIECHV state planning process, which provided information about the risk factors and service needs they saw in their highest risk communities. And based on that, they recommended particular communities to receive MIECHV funding in their states. One piece of the national evaluation is to analyze those needs assessments and to describe what those found. The second is an effectiveness study, which we've talked about reporting on variations in impact for sites and populations with different characteristics. It will also study the effects of MIECHV programs on health disparities and health outcomes. And the effectiveness study incorporates an implementation study that really will take a close look at how the local programs operate from the perspectives of the program administrators, the supervisors, the home visitors, as well as the families. And finally, MIHOPE will include an economic evaluation that will be looking at the cost of the MIECHV programs and how those costs vary with different characteristics of the programs as well as the families that they're serving. So we're now on slide 11. How will we learn about the needs of communities operating MIECHV programs? So one aspect of the evaluation is to be able to describe the communities that are part of the MIHOPE study. And as I said, we'll be looking at what things looked like before MIECHV launched, the current home visiting practices that states described in their needs assessments, the community's needs and gaps in services that were identified, and how the states intended for the MIECHV home visiting to address those gaps. And to answer those questions, down at the bottom you'll see we have several different sources of data. We'll be going through the state needs assessments themselves, the state plans and their competitive grant applications. And we'll also be conducting interviews with the state MIECHV administrators to hear how their program plans were developed at the state level. Now, how will we learn about program impact? This is slide 12. The first question here is that we can answer with the random assignment design is how the outcomes for families enrolling in MIECHV home visiting compare to similar families who did not get home visiting. So we'll be looking at several different aspects of family life, including maternal health, parent well-being, family economic self-sufficiency, child health and development, and parenting practices. We'll be looking at whether some families benefit more than others. For example, do families who enter the program when their child is a newborn benefit more than those who enroll later? Or do families with particular risk factors when they enroll in the program benefit more or less than other families? What are the impacts for each evidence-based home visiting model is another question we'll be able to answer. As long as we are able to include enough sites and families for each of the four models, we will be able to group together the local sites across the country that use a particular model, and we'll be able to report on the impacts for each of the models separately. And again, to answer these questions about the program's effectiveness, we'll be able to look at data from a number of different sources. 3 kinds of state records for each family in the study that we'll be collecting include vital records for birth outcomes, child welfare data, and Medicaid data. The study's field interviewers will also be doing surveys with the parents at 2 points in time. They'll do one survey of the parents when they enter the study, which you'll sometimes hear us refer to as the baseline survey. And then when the child is 15 months old, we're also proposing to do another study with parents, another survey with parents, as well as some direct assessments of the child's development at that time, and some videotapes of the parents interacting with their child. So those follow-up instruments are still in the federal approval process, but those are what we're proposing as a 15-month follow-up point. And one thing I just wanted to reiterate is that when we collect these surveys from families for purposes of the study, Mathematica Policy Research will be hiring local field researchers to do this data collection. So the program staff in the sites, they will play an important role in the study, but collecting the data from the families is not one of the things they will need to do. So we're on slide 13. How will we learn about program implementation? So we'll be asking what services are provided and to whom. How are the services delivered to families? For example, how often do home visits take place and which family members are involved? What kinds of topics are covered? What kinds of methods are used for engaging families? And how close is the number of home visits provided to the number that the program model intended to provide? We'll also be looking at what are the characteristics of the families that are in the program, what challenges do the staff encounter, and how are they addressed? What alternative programs are available in the community, and what services are available that programs can refer families to? What program characteristics are associated with family engagement in the program over time, and what program characteristics are associated with bigger impacts for family outcomes. For example, we might see greater engagement for families when home visitors have a certain level of support or clinical supervision or weekly supervision. Do we see greater impact when programs have strong coordination with their referral networks? There are a number of different questions we'll be asking about how programs operate and how those seem to influence impact. The data sources we'll be using to inform the implementation study include the ones listed here at the bottom. We have what we call MIHOPE logs, which are weekly web-based forms that we're asking home visitors and supervisors to fill out about how they work with families on an individual level. And for supervisors, we'll have them fill out logs about how they're working with home visitors that they supervise. We'll have web-based surveys for staff that ask them about their understanding of the program's goals and other perceptions they have of the program. We'll be having the managers complete inventories about what tools the programs use, such as particular screening tools or curricula that the staff use, and also inventories of what services are available in the surrounding community that they can refer people to. And finally, we'll be doing some in-person interviews and phone interviews with program staff that will go into more depth on a few key issues that might emerge. Oh, and last, we'll be doing some video recordings of a selection of home visits in each program site, really to understand the quality and the content of the services being delivered and the relationship between the home visitor and the family. We want to understand that in a depth that we really could only get by either being there and observing a home visit or by videotaping a home visit. We are now on slide 14. So how will MIHOPE learn about economic effects? To learn about those effects, we'll be estimating the cost of the services for the average family in each site, and we'll also be looking at the cost of the program overall in each of the sites, and how those costs compare to the impacts that are generated by the program. So to answer these cost questions, we'll be collecting some annual fiscal data from each of the local programs, and also some information about how many families they serve per month, and putting that together with information from the weekly service logs that the home visitors will fill out, so that we'll know something about how much time the home visitor is spending on their work for each particular family they're working with over the course of a week, and we'll collect those logs over time. So one interesting thing here about the cost study is that we'll be able to link higher or lower costs to particular families, because we'll be able to look at how different families take up more or less of the home visitor's time, which would in turn lead to higher costs for the program or lower costs for the program. And then we'll be able to tell whether the kinds of families whose issues might lead to higher costs and a lot more service provision, we'll be able to tell whether they also end up showing a higher than average benefit from the program or a lower than average benefit from the program. So we'll be able to tell a lot about whether the sort of time expended by home visitors is paying off for those higher risk or higher cost families. So those are some of the main research questions that we'll be tackling in MIHOPE. And with that, I'm going to turn it over to Sharon for the next slide.
Okay. Thank you, Ginger. So staying with the research, I'm going to talk about one of the key characteristics of the research, which is random assignment, which is we've used a few times. So so families each of the 5,100 families that meet eligibility for the study will have a chance of being assigned to one of two groups. One group called the home visiting group, which means those families would then be enrolled in the home visiting program and receive the regular services that would be expected of their participation in the program. And the other 50% would be assigned to a non-home visiting group, which means they're not eligible to receive services from that program, but could go into and receive services from other programs that are located in that community. And what we will do is follow both of those groups over a period of time and track and see what happens to both of those groups. And that's how we do the study. So we do this using random assignment, and the next few slides cover some of the how and why we use this research methodology. So we use random assignment because it is still the most reliable way to measure program effects than really any other kind of method, or including trying to create statistical controls, looking for comparison groups in another community or another part of town. This is a reliable way of really being able to track the effects the program has. And it's more and more widely used in social service settings. And the important thing about random assignment is it really allows us to measure the actual effects that program services have, rather than providing and reporting on program outcomes, which may or may not be attributable to the program. And frequently, programs report on outcomes, and a lot of times they're asked to report on outcomes by their funders. And these tend to be accomplishments or achievements that can be quantified, like the number of expectant mothers receiving prenatal care or infants up to date with immunizations. But random assignment allows us to measure how the outcomes for those in the program compare to those in the comparison group. And because the only difference between those two groups is the receipt of these particular services, then we can say the difference in the outcomes is the impact of the program. So it allows us to, and Ginger talked about subgroups. So with a large enough sample, you can actually look at parts of your entire groups who share key characteristics that as she mentioned. So what is random assignment? So random assignment is a lottery-like process to place individuals into two groups. It's a fair and equitable way to determine who receives program services. And in fact, although random assignment is a research methodology, it's frequently the case that programs who are oversubscribed, who have more people applying for their services than they can actually serve, will use a kind of a lottery process to determine who goes in. But when you do a random assignment process, it also allows you to measure the impacts or the effects on outcomes for each group, not just for individuals within the group. So this next slide shows what the difference is between looking simply at program outcomes versus looking at impacts, and allows you to really determine what the effects of your program are, as opposed to the actual just looking at the outcomes. So in this particular slide, this is made up statistics, but we're looking at the percent of families who are up to date with immunizations, whose children are up to date with immunizations. And there's three separate programs, Program 1, Program 2, and Program 3. The green bar shows what's happening with those families who are in the program group. And if you only looked at that one green bar, it would be easy to assume that Program 3 is the most effective program because it has the highest outcome, which is this percent who are up to date with immunizations, whereas Program 1 has a pretty low outcome. However, if you include a comparison group, what you see is a different story. Even though it doesn't change the percentage of outcomes, what it does show you is what the difference is, what happened because of the program, or what instead of what would have happened without the program. So you see in the case for Program 1, although only 40% of the children actually are up to date on immunizations, that's twice the number, twice the percentage as those would have without that, as would have happened if the program didn't exist. Whereas in Program 3, which looks the most effective just looking at outcomes, actually didn't improve outcomes over those other comparison group families. It doesn't mean the program's not effective. It just means in this particular outcome, it wasn't able to improve over what was happening for without the program. And so what you don't know when you look simply at outcomes and try and compare programs is, are there different population characteristics? Maybe the program one is serving families who have more barriers, or it could be just some issues having to do with access to medical care in the community. There may be many more services in the community where Program 3 is located than Program 1. So what random assignment allows us to do is actually look at what's the difference the program makes. Uh-oh. Sorry about that. So there's some key principles related to random assignment. So as we talked about earlier, it is fair and ethical when there are more families than program slots for families. So in other words, random assignment is not something that's so easy to do in a program that where everyone who's entitled to receive those services, where there's adequate funding for everyone who's entitled to receive services. But in a situation in which there are more eligible families than there are program slots, random assignment becomes another way of determining who can receive services or who is eligible for services. It shouldn't reduce the number of families who get services. So the same number of families should be filling the slots in a program, whether or not a random assignment process is underway. And in fact, in the case of MIECHV, because we're building on existing programs, or we're evaluating programs that were already in existence and have experience, these are programs who are now serving more families than they were prior to MIECHV. So again, it's not reducing the number of families who get services. It shouldn't change the basic eligibility criteria for services. One of the things that I mentioned a couple of slides back is that families who are eligible for the study would go through this random assignment process. In many cases, in some programs, not every family who wishes to enroll in the program is actually eligible for the study. We're looking at families where there's a child 6 months of age or younger. We're looking at families where the mother is over 15. So if families who enroll or who apply who don't meet those criteria would still be eligible to continue applying to that program, they just wouldn't be eligible for the study. And for MIHOPE, parents' decisions about whether to be in the research doesn't affect their likelihood of getting home visiting services. So it's their choice. They get to choose whether or not they wish to participate in the study. So I am actually leaving now a description of the research and moving on to some of the roles and responsibilities. And so going back to the 12 states and the 85 programs that we would like to have in the study, we're asking some key things from both states and from programs. So for states in particular, we're asking them to reach out and help us with our recruitment of program sites. So one of the things that makes a state eligible, or some of the things that make them eligible are, as Ginger said, we're supporting more than 2 of the models and having multiple sites. And so it's the sites, partly the site's eligibility for being in the study that makes the site eligible, and so we need the state to work with us to reach out to those sites. We're also asking for the state to help negotiate access to state administrative records for the purposes of the study. Ginger mentioned those before. Vital records, child welfare, and Medicaid are the ones that we're particularly looking for. As far as the programs, we're asking and looking for sites who can recruit approximately 60 families, 30 for the program group and 30 for the comparison group, and that's over a year to a year and a half. We're asking that the staff and the administration, meaning supervisors and program managers, participate in some interviews and surveys that we'll be doing as part of the study. We're asking for programs to provide records such as staffing records, information about staff training, and information about program costs. we're asking staff to complete and submit program participation logs. That's the home visitors and supervisors. And we're asking programs to facilitate the home visits that will be videotaped by research staff. And our staff will do the videotaping, but we're basically looking to find families who might be eligible and willing to participate, as well as home visitors who'd be willing to. So these are some of the things that the research team will do in addition to what we're asking from states and programs. Obviously explaining the research design, providing training on procedures, and we're enrolling program participants in the study and collecting data through the from the various data sources that Ginger mentioned earlier. We're providing funding, and we're analyzing data, providing results, and disseminating information. So what we like to think of what are the supports that we're trying to provide to sites to participate in the study, and these are some of the key ones. And so we're providing training to staff in a one-day, what we're calling a kickoff event, that we're trying to do centrally in each state. In some states it will be probably 2 different events, either because of geography or simply the number of sites that are involved. We've tried to take the burden off of the programs of enrolling families in the study, so it's actually MIHOPE staff who are located in those communities who will actually reach out to the families and enroll them in the study. We, for the purposes of MIHOPE, are assigning members of the MIHOPE study team to be key contacts for each of the states and each of the sites, so that both the state and the sites that are in the study know if they have a question or a concern that who they can contact to for information, for support, and for help. We've tried to make most of the instruments web-based and very simple to do. We've field tested them to make sure that they're easy to understand and don't take a long time to do. We're providing program funding of about $22,000 to each of the program sites that's provided over 3 payments. And what we're working individually with sites who will be in the study to develop a list of referrals, because one of the key issues, of course, is if families are assigned to the comparison group, what does that mean for them? Where can they go? And so this is something that's done at the individual site level as we work with them on what's the list of referrals that they can give to comparison group families. And we're also develop scripts and are developing a video for local programs that they can use to explain their participation in the study to their referral partners and also to applicants of the program. So just briefly, what we're trying to do at this kickoff training that I mentioned earlier, there are mainly 4 pieces to it. One is to explain to them about MIHOPE so that they understand what the study is, why we're doing it, and basically something fairly similar to what we're doing here. And we're doing that at the beginning because not all of the staff will have had an opportunity to hear from us directly about the study prior to this point. So this is their opportunity to ask questions about the study and really understand what we're trying to accomplish. We're exploring with the sites how to talk about the study with applicants and referral partners, as I mentioned earlier. We're explaining and demonstrating how to use the automated intake system, which is a system that sites will use in order to send us information on families who are eligible for the study so that our staff can go out and invite them to participate. And we're also providing instructions and demonstrations on how to do the logs and the surveys at the kickoff training. And that is an overview of MIHOPE. So if you have, we're going to have a question and answer period now, but if you need more information, this last slide shows who you can contact and give their contact information. So Lauren Suplee and Jill Filene are the 2 email addresses that you have here. And so, Jill?
Okay, thanks. So as a reminder, if you have any questions, you can submit them in the bottom right-hand corner of your screen. There's a tab, Q&A, and you can submit your questions there in writing. And I'll start with the first question, which is, if a client drops out of the program, will another client be recruited to ensure that 30 clients have been followed from each site?
I guess I can take that one.
Right.
This is Ginger. So the way it works is that once a person is in the program group, so one of the 30 who are in the program group, whether they stay in the program for the full amount of time that the program would like them to participate or whether they drop out actually does not affect whether they stay in this program group for the study's purposes. So all of the folks who are first assigned to that group through random assignment will be tracked by the study, even if they drop out of the program. So we keep doing random assignment until we have about 30 people in the program group and about 30 in the comparison group. But we don't then replace people just because they've dropped out in the program of the program. We keep following people up to the point of the follow-up survey for families, whether or not they're still in the program.
Okay, and in this idea of enrollment, the next question is, how are the 60 families from each site selected? Are there any selection criteria?
I can answer that. This is Sharon. So the selection criteria are that they need to be at least 15 years of age and pregnant or have a child who is 6 months younger than 6 months old, and so. In some cases, in the case of Head Start, they're not early Head Start. They're not homeless or in foster care, and so if they meet those are the basic eligibility criteria for the study. And so every family is essentially entered into the system, and we're looking for families who meet the eligibility criteria, and we will go out and talk with them. And essentially, what we do is enroll families in the study until we reach our 60. So we're not kind of picking and choosing among families who meet the basic eligibility criteria. It's the first 60 who are enrolled in the study.
Sharon, this is Lauren. Could you also explain about the normal intake process?
Okay, sure. So the way the intake process works is this. We when sites get information about families who are eligible, they're either referred to them or maybe they've been, or families have come in and filled out an application. Once a family has been determined to be eligible for the program services, and remember that could be different than the study eligibility, so they're eligible for that program and have expressed interest in participating in that program. We have an online system where a few key pieces of information are entered by a study intake person at the program site. So this is a program staff person. And so it's basically the name and some contact information. And that information, once we determine at our end that that family meets the study criteria, eligibility criteria, our field staff person then reaches out and contacts that family and sets up an appointment to go out and meet with them and to explain what the study is, what's involved in the study, and ask for the family to consent if they're willing to be a part of the study. And if they do consent, at that point in time, they complete this baseline survey that Ginger mentioned earlier. And the survey, even though the person is in their home, the survey is done by telephone, and we've decided to do it that way because it increases the confidentiality of the answers to the question. So it doesn't matter if at that home there are other family members around, the other family members or other people in the household are not hearing the questions that are being asked of the person. And so following that process, the field staff person leaves, the family is randomly assigned, and then the information on their random assignment status, whether they've been assigned to the home visiting group or the comparison group, is then transmitted electronically back to the program. And so they then either reach out and enroll that family if they've been assigned to the home visiting program, or contact them to provide them with referral services if not.
Okay, great. And then thinking about this idea of intake, how is the study addressing the model's requirement for engaging clients within a specific time frame?
Oh, do you want me to take that, Ginger?
Sure.
Oh, okay. Well, so our goal is to try and reach out immediately after we get the information, and we're trying to complete that entire process within a 48-hour period, or at the very least to have reached out and made an appointment within that 48-hour period. If we're having difficulties reaching the person within that time period, then we would go back to the program to either get some assistance in reaching out to them and eventually, and to see how it's going for the program and if we can get a little bit more time. And if not, then that family would not actually be enrolled in the program because we won't hold them up indefinitely while we're trying to do that. And we do understand that there may be some circumstances where the need is even faster than that, and so we set up ways for the programs to get in touch with us to say, you've got to reach out to this family even faster because, for some particular reason. Maybe because of their eligibility, they may be aging out of eligibility for the program services. Jill?
Okay, next question. A participant asks, I appreciate the focus on existing agencies, but how are expansion home visitors treated? They are still new to the model and learning implementation. Are new staff excluded from recruiting clients for MIHOPE?
So the answer is no. We actually are including new staff. There really isn't a way, I don't think, to do this kind of study of a new funding stream. If we were to completely exclude new staff, we probably would not have very many people in the study. So our way of handling it is to make sure that the managers and the structure of the program have been in place for a while, but we are including both new and existing staff.
Okay, next question. What states are participating in the study?
Okay, so Pennsylvania at this point has moved all the way through the kickoff training and is actually enrolling families in the study. In addition to that, we have HHS has approved us to work with Illinois, Michigan, Wisconsin, Georgia, Nevada, 1, 2, 3, 4, 5. I think I got them all. So those are the ones that have been approved. And we're moving forward with reaching out to the sites to reach agreements with them and also with the state and to schedule the kickoff. In addition to those states, we've made visits to Kansas, California, Oregon, Washington, and we are about to visit South Carolina.
Okay, next question. How are videoed home visits selected?
So the way those are selected is that once a site is in the study, we're going to give them a few families. The first few families who are in the home visiting group will not be videotaped, just to let the site kind of get used to being in the study and not add that to their list of things to do. But after the first, I think it's the first 5 families, we're going to be asking if we may videotape the next 9 families that are in the home visiting group. And there are 2 particular sort of time points that we're going to do the videotapes. The first is about 6 weeks after the family enters the program, and so that would be whether, regardless of whether it's an expectant parent or whether they already have a baby, it would be tagged to how long they've been in the program. And then the second videotape would be, I think it's when the child is about 5 or 6 months old. And so for parents who come in when they're expecting, it would take a little longer to get to that point. For parents who already had the baby when they enrolled, it would be a little bit sooner. But the second one is tagged to the child's age so that we can have some uniformity in sort of what might be going on in parenting at that point in the program. And beyond that, the home visitor and the parent both have to consent to be willing to be videotaped, so it's a voluntary activity.
Okay, so the next question has to do with meeting the criteria for the study and asking to expand on the criteria for whether they're exempt from the study, if there are different characteristics for being exempt from the study, and what that process is.
I'm sorry. Can you repeat the question?
Sure. So the question is about families who meet the other eligibility criteria for MIHOPE. Are there other criteria that make them so they do not have to participate in MIHOPE, like being homeless or in the foster care system? And if there are other characteristics, how are they involved in the random assignment process?
So you're going to answer that, Sharon?
No, you can answer it if you want.
So, the short answer is there are not other kind of global criteria that exempt families. Each program is given a handful of about 3 exemptions that they can choose if they have families come through who they feel are so distressed or have, terrible health issues or other things that make them really want to exempt that family from the random assignment process. They can have up to 3 of those that they just make at their own determination without any particular criteria from us. So that's the main thing, I guess, that answers that question. The other thing is that the study is voluntary, so the families do consent to be in the study and have the data collected about them, but otherwise there are not other exemptions from going through the random assignment process.
Ginger, this is Lauren too. I just want to clarify that the homeless and foster care exemption is for early Head Start only because it's noted in the legislation, but for the other 3 models, that's not an exemption.
Thank you, Lauren.
Okay, next question. When will the study team produce reports?
So there are two main stages where we'll be producing research reports. One is a report to Congress, which is due to Congress in March of 2015. So that is when that will become public. That will cover characteristics of families who are enrolling in the programs and some other information about the programs themselves, as well as the piece of the evaluation that's about the state's needs assessments and what those say. Those will all be part of the report to Congress. We will not have finished the impact phase of the study at that point, and so there will be another series of reports around 2017, which will include a full documentation of the program's implementation, the implementation study. It will include the impact report about all the different domains that we're studying, and it will include the economic analysis, as well as the analyses I described where we'll link characteristics of programs to the impact and sort of get inside the black box. All of those will be delivered at a later date around 2017.
Okay, we have a couple more questions. So this is just one last reminder to the participants, if you have any questions, enter them in the bottom right-hand corner. So the next question is, what services are the comparison group members permitted to obtain, and is it the same across the country?
Comparison group members are allowed to obtain whatever services are available in the community that they would normally be able to access. We do work with the home visiting programs that are in MIHOPE to talk with them about what services they are likely to directly refer comparison group members to when they call to tell them that they won't be receiving MIECHV home visiting services. So we work with them on the kinds of services they're likely to refer them to. But the basic answer is that there's no prohibition on enrolling in any particular program other than the programs that are in the MIHOPE study. So if there were two MIHOPE study sites, very near each other, down the street from each other, we would ask them not to enroll comparison group members, in each other's programs. Beyond that, that's sort of the extent of the reach of, what the study can do about, what services people access, and people are, welcome to access other services in the community.
Okay, next question. How will you report on the school readiness domain when you're only studying pregnant women and infants?
So that's a really good question, because school readiness is one of the domains that's named in the legislation, and people do kind of scratch their heads and say, well, if we're working with 6-month-olds, how do we measure school readiness? So in the MIHOPE evaluation, the way we're looking at that is we're identifying some aspects of child development that are seen as kind of early precursors of school readiness. So, basically the full range of children's development, from physical health to social emotional health to their cognitive development and their language development. So in the 15-month follow-up, for example, we're proposing to actually do a measure of the child's language development. And that's one of the aspects of development we'll look at, since we can't really do, something that's at the right age range for what you'd think of as school readiness. We're doing a much earlier version of a developmental assessment.
Okay, great. Well, that covers all the questions that were submitted during today's webinar. We'd like to thank everybody again. The contact information, if you have further questions, are listed on this slide that's on your screen. We'd like to thank everybody for their participation today, and have a good afternoon.